Okay, so those of you that are watching at home, the first thing I'm going to do is take some topics for discussion, and I will record the audio, and then I will try to put some pictures with it that I've been drawing on the document camera. So those of you that are here, I was hoping we could generate some specific questions or the things that you want to talk about. So go ahead. The VA to Q ratios. We have a request to go over. Okay. What else? I'll do my best. So compare and contrast the saliva material. Okay, what else should we cover? Okay, elastin and compliance. Okay, keep it coming.
PO2 and CO2 and the apex and base and how that approximates shunt and the other one.
Okay, that's related to the VA to Q and equity. We can do that too. Yes, and there was a hand up there.
Why arterial PCO2 increases ventilation, where alveolar ventilation decreases with PCO2? I guess let's just go with.
Okay, so why do increases in arterial PO2, arterial CO2, why does that increase ventilation? But then you also want to try to understand why, when you increase ventilation, why that then decreases PCO2. Okay. Okay. So I'm going to go to the document camera. Oh, you want to add more? Yeah, please do.
Peripheral versus central
Chemoreceptors. Okay. I think, if you don't mind, I'm going to start on the saliva first. So, let's see what I can do from memory. All right. So, Dr. Rudney draws the cells kind of this way. And basically, you know, if this is the acinus of a salivary gland, then you've got cells that are shaped kind of like that. All right. I think one thing you should realize is that every single cell is going to have a sodium-potassium ATPase on the basolateral side. And what that means is that there's going to be a gradient for sodium to come in the cell, and for potassium to go out of the cell. Number two. So this is one. Number two, these cells are going to have some kind of receptor. And so, for example, an M3 receptor, acetylcholine from the parasympathetic nervous system. And as I recall, Dr. Rudney just said parasympathetics. I don't think he said facial or trigeminal or which one it is, because I quite frankly don't remember. But ACH is going to affect a G protein, and that G protein is connected to an enzyme called phospholipase C. Phospholipase C takes a lipid in the membrane, one of which is called PIP2, and hydrolyzes it, so you get something called IP3, IP3, and in the membrane you get something else called diacylglycerol. So this is where the movies came in. IP3 is a second messenger that goes to inside membranes and increases calcium. So the first thing is we have a sodium-potassium ATPase that sets up the gradients. Number two, we're going to have means of activating proteins that allow some kind of electrolyte movement. All right? So this calcium inside the cell, number three, there will be a potassium channel on the basolateral side. Now, if we open up a potassium channel on the basolateral side of the cell, where will potassium go? Will it go into the cell or it will go out of the cell? It'll go out of the cell along its gradient. Beautiful. How does this channel know to open? It's calcium activated. And then this potassium is just going to turn around and get pumped back in and go out and pumped back in. All right. Now, what's going to happen on the other side? We're going to have some other channel for a negative ion. So as potassium, a positive ion is going out the back, some negative ion is going out the front on the apical side, and that negative ion will be added to the saliva. Well, what are the two negative ions that are really high in saliva? Chloride and bicarbonate. So in two of the models, chloride leaves the cell. So then we say, okay, if chloride is leaving the cell, how in the world does chloride get in? So, one is the sodium-potassium ATPase. Two is a second messenger to make IP3 so we have calcium. Three is what do we do with that calcium? On the basolateral side of the cell, we open up a potassium channel, and on the luminal side of the cell, or apical side of the cell, we use that calcium to either open a chloride channel or a bicarbonate channel. So, model one is, if chloride is going out the apical side, how in the world do we get chloride in? And we get chloride in with what I call the loop transporter, but it's a sodium, potassium, 2-chloride channel. It's a secondary active transporter. Why is that? Well, if sodium is getting pumped out, then the sodium gradient is driving for this to come back in. And there's some other protein here for potassium and chloride, but who cares? This is the test is on Monday, so we're going to be practical. So, to get this chloride out, we've got to get some chloride in. So we have a secondary active transporter that gets the chloride in, and then chloride goes across the other cell, and now we've got chloride to go into the saliva. Now, in the second cell, I wonder if this will actually write in green. In the second cell, we use, oh, looky there. We realize that water and CO2 can diffuse into a cell, can find an enzyme called carbonic anhydrase, and make bicarb and hydrogen ion. The bicarb then can exchange for a chloride. And then the chloride goes through the apical cell, and now we got chloride going into the saliva. So that's the whole thing. If I got chloride going out the front, how do we get the chloride in? Well, I'm going to use carbonic anhydrase to get in bicarbonate. I'm just going to use bicarbonate to get in chloride. And the third model is, why in the hell are we messing around with chloride? Oh, I just swore on the recording. I apologize. Okay. And we say, well, why not just use the carbonic anhydrase system, make hydrogen and bicarb, and we'll send bicarb out through the channel. And I don't even need to deal with chloride. And now I've got bicarb going out in the saliva. All right, so what's number one? In order to do any of this, we need a gradient for sodium and potassium. That's the pump. In order to get the secretion started, we need a source of calcium. That's acetylcholine binding to a G protein coupled receptor, driving phospholipase C, getting us calcium out of the ER. That calcium drives potassium out the back, some other negatively charged thing out the front. So that's 3. And I'll put 3 as potassium goes out the back, and then some kind of thing goes out the front. It's either chloride or bicarb. And then number 5 is, how do we either get bicarb or chloride into the cell? We can use a secondary active transporter for chloride. We can use carbonic anhydrase and get in bicarb and exchange bicarb for chloride and put chloride out the front. Or we can say the heck with chloride, let's just use bicarb, again with a carbonic anhydrase system. So to me, those are some touch points you can think about. I mean, maybe you have a good memory and you can just memorize the cells and draw them on your exam for one question. But those are the patterns, right? Yes, sir. So when I say carbonic anhydrase system, what I mean is, on the basolateral side of the cell, CO2 and water come in by diffusion. They meet carbonic anhydrase, make carbonic acid, which then dissociates into a hydrogen ion and a bicarb. Now, the bicarb going out for chloride, that's facilitated diffusion. Okay? But if you think carbonic anhydrase system, then you've got a peg to hang the concept on and you can flush it out later. To me, that's a big thing. Now, the other part that I will just confess I don't understand as well, I'm going to move the paper over here a little bit, is that saliva also has protein. All right? So somebody has, maybe they have a mutation and they have trouble making saliva. People with cystic fibrosis have a chloride channel mutation and they get real thick mucousy saliva in the mouth because it's not watery because they can't do that water and hydrogen secretion. Oh my gosh, I almost forgot. There's a 6, and that is These cells are held together by tight junctions. Sodium comes through the tight junctions, and then there's a little aquaporin for water to follow osmotically. So you got a sodium chloride or a sodium bicarbonate solution with water following to bathe the teeth. The other thing I got from listening to Dr. Rudney is that variable. Secretion varies depending on the stimulation. Secretion varies from person to person. Secretion varies over the lifetime. Secretion varies in the mouth. It's not mixed evenly in the mouth. Variable. So if you were to see something's the same or even, that an alarm bell ought to go in your head and say, oh, that can't be it, because it's so variable. And I'd say that's another thing to think about. And that's the difficulty clinically, because dry mouth that bothers me might not bother you. The other aspect of saliva, though, is that it's got lysozyme and amylase and those things in it, though he didn't call those proteins by name. I assume he talked about that in biochemistry when he did the proteins. But saliva also has a protein component. That's a different ligand, and that's the sympathetic nervous system. So for a cell, and I'm just going to draw another one here, somewhere there's got to be a cell that binds norepinephrine, and that's a beta adrenergic. And I can't remember, it's a beta 2 or beta, it's a beta 2. All right. Thank you. We have confirmation from the audience it's a beta 2. What do we need the norepinephrine for? Well, that's how we get the protein. Now, how do I remember that? An old-fashioned lie detector test is you'd give somebody some pebbles to put in their mouth, and you make them tell their story, and then you have them spit out the pebbles. If the pebbles are really wet, they were calm and they're telling the truth. If the pebbles are really dry and sticky, they were upset and not telling the truth, so there's more sticky protein. However, it's not the dual innervation. When we talked about this in the cardiovascular system, you stimulate the sympathetics and the heart rate goes up, and you stimulate the parasympathetics and the heart rate goes down. It's not really like that. The stuff is cross-talking. So as I recall from the lecture, Dr. Rudney really emphasized that as well. So we're going to have norepinephrine, and norepinephrine activates cyclic AMP, and you set off a pattern that causes exocytosis, and you exocytose protein into the saliva. Now, I can't remember this off the top of my head, but there was a slide with 4 cells on it. And if you had low parasympathetic stimulation, low cholinergic, then you'd get a little bit of water secretion, and if you had medium of both, then you'd get some other kind of pathway. It's not, I'm not taking the test on Monday, so, I didn't spend a lot of time studying this, but there's something about that slide. And the reason why I say that is I wrote learning objectives for Dr. Rudney, and then that crosstalk one, that was the one he rewrote, which told me that was important to him. And I don't think it's, oh, that's it right there. What is your name, sir? Okay, hold it up so the rest of the class can see. You see the little 4 blue cells? That's the one. So, dual innervation is you stimulate the sympathetics and the saliva goes down, and you stimulate the parasympathetics and the saliva goes up. That's not what happens. You stimulate differing ratios of sympathetic and parasympathetic, and you get saliva that has more water or more protein. So they're working together and they're interacting. That's crosstalk, as opposed to one takes you up and the other takes you down. All right? So I'm not any much help than that. But how do you get the protein out? Some kind of exocytosis. And there are classical pathways, and then there are some other pathways, and I would recommend looking at that a little bit. I'm sorry, I mean, it's not in my head, but that's some things I would think about. I don't know. Was any of that helpful? Is that enough to go on to something else? Okay. All right, so if you're listening at home, this is picture number A, letter A, and I will make a scan of that and put it with a recording. Okay. Because I'm a Luddite, and this is as good as I can do. Okay. So then our next thing that we want to talk about is going to be, I'm going to talk about these two things together, VA to Q ratios and PO2 and PCO2 in the base and the apex. I'm going to talk about those as one kind of thing and draw a picture that goes with this. So this will be picture B. All right. So humans have all kinds of interesting things to deal with because we're upright animals instead of, you know, walking around on fours. And so gravity affects us in a couple of ways. Okay, this is the apex, and it's called that because the top of your lungs have sort of a little pointy place on them. And Dr. Cook would really love that. And the bottom is called the base. It's the bottom. All right. So the apex is stretched out. And the base has room to stretch. The apex has low hydrostatic pressure. And the base has high hydrostatic pressure. Therefore, because of the effect of gravity, and because the apex is pretty stretched out, but the base has room to stretch, if you think about from the top to the bottom, ventilation increases. Independent of what blood flow is doing, ventilation increases. Okay. Because the apex has a low hydrostatic pressure and the base has a high hydrostatic pressure, if we think about flow from the top to the bottom, flow increases. That's why if on a test question I just talk about ventilation in the base, ventilation is higher in the base than in the apex. If I just talk about perfusion, perfusion is higher in the base than the apex. So everything ought to be hunky-dory. The problem is they don't change in the same way. Yes, ma'am. I am, and flow or perfusion is in mils per minute. So some portion of the cardiac output in mils per minute, some portion is going through the top, some portion is going through the middle, some portion is going through the base. Of that 5 or 6 liters, most of it's going through the base. Likewise with alveolar ventilation, there's 4 liters. Some of that 4 liters is going to the apex, some of it's going to the middle, some of it's going to the base. Most of it's going to the base. The problem is the PO2s and the PCO2s, which is the other part of that question. what are PO2 and PCO2 in the apex and the base, they change a lot, because if you take the ratio of the two, the ratio is a whole nother deal. If we just look at the base and we look at the ratio of air and blood, ventilation and perfusion, there's more air than blood. Both of those two numbers are lower than the two numbers we'll see in the base, but in terms of a ratio, the ratio is weighted towards ventilation. So the apex is somewhere in between dead space and perfect. Now what the heck is dead space? Dead space is ventilation without blood. So the air looks like what's outside. It's high in oxygen and hardly has any CO2 in it. So then you take that air and you put it in the top of the lungs and just expose it to a little bit of blood. Just a little bit of oxygen is unloaded and just a little bit of CO2 is added. So where the ratio is high, the PO2 is going to be higher, and instead of 100, maybe it's 120. And the PCO2 is going to be lower, maybe it's 35 millimeters of mercury. So the apex is somewhere in between dead space, where there's no exchange and we don't lose any oxygen, and perfect, where we have good exchange. Somewhere in the middle, the ratio is 1. And whenever there's a ratio of 1, we expect PO2 to be 100, PCO2 to be 40. And when we're undergraduates and we learn about the lungs, they lie to you and say, oh, everything's even, and that's the whole thing, and it's not really that way. So somewhere in the middle, the ratio is equal to 1, PO2 is 100, PCO2 is 40, and again, we're in millimeters of mercury. Okay. Now at the base. All right. At the base, that's where the highest ventilation is. That's where the highest perfusion is. But daggone it, there's actually more blood than O2, or more blood than ventilation. And so the ratio is less than 1. So it's somewhere in between shunt and perfect. And what the heck is a shunt? A shunt is blood with no ventilation. And shunt blood looks like venous blood, because the blood doesn't have access to the air in the lungs. So it's got a venous PO2 of 40 and a venous PCO2 of 47. So the bottom of the lung is going to be somewhere in between shunt and perfect. So the PO2 is going to be something like 89. And the PCO2 is going to be something like 42. Okay. The apex is going to exchange and send blood toward the pulmonary vein. The middle is going to exchange and send blood toward the pulmonary vein. And the base is going to exchange and send blood toward the pulmonary vein. This is going to be high in oxygen. This is going to be medium in oxygen. This is going to be low in oxygen. Well, what does the most work? The base. So because the base is a little low in oxygen, it depresses the total. It depresses the average. So if your alveolar PO2 is 100, in the pulmonary vein, it's 95. And you're saying, holy Toledo, Dr. Anderson, that's so friggin' complicated. Who needs to know that? Well, if your patient is healthy, you don't need to know that. And quite frankly, when they're lying back in the dental chair, their perfusion is much more even. You don't have to deal with it. But part of my job and part of the job that teaches you the medical dentistry or whatever that course is. And I'll also say, I had a meeting with Dr. Mays the other day, and May or Mays, I can never remember. It's May, just May. Or is it plural? Mays. Okay, whatever. Keith, Dean. And the thing that's going on with the board exam is that the board exams are more integrative. And they're asking you to integrate this information in more clinical kinds of scenarios, and we're trying to figure out how to do that to prepare you for the boards. And the thing is, if you have a patient with emphysema and they come in, and maybe they're bringing their oxygen with them, but you just have to be ready for the idea that the air that they're breathing doesn't oxygenate the blood as well because of their disease. So their alveolar PO2 might be 90, and then their arterial PO2 then might be 75. Well, and I don't know if you can put in a nasal cannula while you're working on their teeth. You've got people who know what they're doing to tell you those kinds of things, but we have to be aware of the fact that there are a lot of people with chronic conditions that need dental care, and you have to make sure they're all right while you're helping them with their teeth. Yeah. When we say the pulmonary vein, we say that's the blood that's oxygenated and going back to the left heart.
Yep. So we said PO2 that's 95.
Uh-huh.
So when we have a PO2 of 89 in the alveolar base, does that mean oxygen is going from the pulmonary vein into the lung? Do you know what I'm saying?
So blood from the pulmonary artery went into the lung.
Yeah, okay.
And at a single alveolus, diffusion is perfect. If your alveolar PO2 is 89, then the blood in that capillary is 89. But because, yeah, but see, you had to average it with the stuff from the apex. So, you see these ratios? This ratio is greater than 1. This ratio is equal to 1. This ratio is less than 1. If you average that over your whole lung, the average is 0.8. I was hoping that would light a light bulb, and it didn't. If your average is 1, your PO2 is 100. If your average is 0.8, it's going to be lower than that. Okay. Yes, sir. No. What? No, I'm not saying. Here the PO2 is less than in the vein, and the vein got up to 95 because the 120 and 100 brought it back up to 95.
So it's not like where like the peripheral fusion comes in, so like 95.
Yes, but that 95 doesn't reflect diffusion. The 95 says because we had 120 at the top and 100 in the middle and 89 at the bottom, and when you mix that all together in the pulmonary vein, it averages out to 95. You're almost there. It might need to marinate a little bit more. Other questions about that? All right. Okay, so let's talk about, so those of you who are in your pajamas at home, that's picture B. And now on our list, I'm going to go to Elastin and Compliance. Okay, so we're back to a drawing of the lungs. I like this pen better. And you have to remember, we have all these little alveoli. Your lungs are filled with all these alveoli. And out in the interstitium, there's a weave of elastin and collagen. Now, elastin and collagen themselves do not stretch, but they are woven and cross-linked into a network of fibers, and the network of fibers stretch. So people at home can't see this, but I have this stretchy dress. It stretches, but the fibers themselves do not stretch. It's the weave, it's the network that gets you the stretch. And so I joked in class that you all have a sweater in your lungs. So the elastin and collagen fibers are important because they allow the lung tissue to expand and accommodate air. And not only that, but they allow the lung tissue to recoil when the air is leaving. And so when you're young and when you're healthy, you have a nice arrangement of elastin and collagen fibers that stretch when you need them to and recoil when you need them to. Another name for that structure would be called your extracellular matrix. So you have elastin and collagen in your tendons and your ligaments. You have elastin and collagen in areas where your skin is attaching to the tissue below. But the matrix in the lung is stretchy. And it stretches, and that stretchiness we call compliance. And it returns, and that returning we call elastance or recoil. And you need a nice balance of the two. If your lungs are not very stretchy, they're stiff. You have restrictive disease, and you have to work really hard to expand the lungs to get air in. And that's hard to do. That's, for example, somebody could have fibrosis or something like that. If your lungs are too stretchy, yeah, you can stretch them out, but they don't recoil very well. And there are two things that do that to you: age and cigarettes. How does that happen? Well, your matrix is constantly turning over. And you have enzymes that synthesize elastin and collagen, and you have enzymes that break them down. And cigarette smoking and certain mutations and general aging mean that over time you lose protein. And so there's a network of elastin and collagen fibers that actually holds your airways open. And if all the material starts to break down, then your airways lose their integrity. So you start to exhale and your airways just go splat and you can't get the air out. Emphysema is a very unique situation in terms of increased compliance. And really what you're losing is recoil, and you're losing the integrity of the airways, and they just collapse on a moment's notice. So if you ever go over to the VA Medical Center and walk around and you look at the Korean and Vietnam vets who were given cigarettes, they have these gigantic barrel chests. Why is that? And most people their rib cage tends to increase as they age anyway. You know, and you think about your uncles and your grandpa and that kind of thing, they have big rib cages. Why is that? Because as you age, the proteins in your lungs break down and you lose your recoil. And you can actually see it in the rib cage. Do you know what I'm talking about? Okay. Sometimes I go on a riff and then I think, do they have any idea what I'm talking about? Okay. So the quality of the tissue is one part of compliance. Now, what can happen if you have a bad infection? If you have cystic fibrosis and awful mucus clogging up your lungs, you get infection after infection after infection, and your airways and your lungs start to scar, and scars don't stretch. You have tuberculosis and you get these little granulomatous tumors. They don't stretch. You work around asbestos or in certain industries. People are exposed to things in the workplace, and you get a condition called mesothelioma. Your lungs get scarred and they don't stretch. That means your compliance is going down. Because instead of that stretchy elastin and collagen, you've got scars. Okay. Now the person who asked about that, how can I help you more than that, or is that doing what you wanted? Yes, sir.
Summarize real quick? I think it was like three lung diseases that we just talked about: restrictive, emphysema.
Oh, okay, so we have two major categories. So the question was, what are the two major categories of diseases? Restrictive is a decrease in compliance, a difficulty in expanding the lungs. The second category is obstructive. Obstructive is high airway resistance. COPD, chronic obstructive pulmonary disease, which can be emphysema or chronic bronchitis, and asthma are your obstructive diseases. Emphysema is weird because you have high airway resistance and increased compliance, and the two things are related. The thing that's increasing your compliance is what allows the airways to collapse and increases your airway resistance. Okay, does that help clarify? Yes, ma'am.
Related to that, could you explain why percent FEV1 can show an obstructive disease but not a restrictive?
Okay, so then the question is, can we talk about percent FEV1? So remember, percent FEV1 is what we measured in lab. So I'm going to go back and draw on my picture a little bit more. So what you did in lab was you took a big breath, and then you blew it out, 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 and you measure, I don't know how much a second is, but you measure how much you blow out in 1 second. That's your FEV1. And you measure how much you blew out total, and that was your forced vital capacity. Then you take the ratio of those, so percent FEV1 is the amount of air you blow out in 1 second divided by the amount of air total. All right. So that is a measure of airway resistance. If you have high airway resistance, you can eventually blow the air out, but it'll take you a long time. So the amount you can blow out in 1 second is smaller compared to the whole amount of air you can blow out, which is your FVC. So, if you are healthy, and FVC let's say a person's forced vital capacity, let's say that's 5 liters. Okay? If what they can blow out in 1 second is 4 liters, and we take the ratio of that, that's 80%. That's a nice percent FEV1. All right? Now, the person with restrictive disease can't breathe very much, but there's nothing wrong with their airway resistance. The problem is the compliance. So our person with restrictive, maybe their FEV1 is 2 liters, and their forced vital capacity is 2.5 liters. So both of their volumes are reduced, but their percentage is the same at 80%. However, the person with obstructive, maybe their FEV1, maybe they blow out 2 liters, but their total that they blow out, and this should be 2.5, the total they blow out is maybe 4 liters. So their percentage is 50%. So if I'm a pulmonologist and I do a percent FEV1, I could see that both their values are reduced, but their percentage is going to be normal if they have restrictive disease. If they have obstructive disease, I'm going to see their percentage is going to be low, less than 70%. How we doing with that? Okay. Okay, so this is page C that I just finished with. So those of you listening at home, now I'm going to do these next two together. So one question is why arterial PCO2 would increase ventilation, and then why would an increase in ventilation decrease PCO2, and what's going on with your peripheral versus your central chemoreceptors. I'm going to do those together. That's the chemical control of ventilation. Okay. First of all, we have to realize that one of the reasons why we need to know what alveolar ventilation is, and in a healthy person, it should be around 4 liters per minute. Is that alveolar ventilation is matched to the person's metabolism. So, metabolism is going to determine a person's CO2 production. And that's called CO2 production. V.CO2. So that's how much CO2 you make. And then P little a CO2 is how much blood's in your, or how much CO2 is in your blood. P big A CO2 is how much CO2 is in your alveoli. So little a is arterial, big A is alveolar. They're in communication and they tend to be a similar number. So if my metabolism stays the same, and I increase my ventilation, I'm going to get rid of CO2 faster than I'm making it. So if I increase V minute ventilation, but my metabolism is the same, I unload CO2 faster than I'm making it, and my PCO2 will go down. The opposite is true. If my ventilation goes down, but my metabolism stays the same, then I'm making it faster than I'm getting rid of it, and my PCO2 should go up. Oxygen is going to be the opposite. So your alveolar ventilation is how much you need to be ventilating your alveoli given your metabolism. So if I breathe more than I need to, I'm hyperventilating. So when I hyperventilate, I blow off CO2 and I build up O2. And building up O2 doesn't mean it no good because I was 100% saturated before I was hyperventilating, so who cares? If I'm not breathing enough for metabolism, and that's hard to do when you're conscious because the drive to breathe is just so strong, but I take a drug overdose, or I fall off a ladder and hit my head and damage my respiratory centers, if I'm not breathing enough, I'm using up oxygen but not bringing it in as I should, my PO2 will go down. I'm producing CO2, but I'm not getting rid of it as I should. My PCO2 will go up. So we have to start there, that alveolar ventilation has a tremendous influence on our partial pressures of oxygen. And if I have a drug overdose and they take me to the hospital, they're going to put me on a ventilator. Yes, I need oxygen, but it's just as important for me to get rid of the CO2. If I don't get over the CO2, I'll go into acidosis and I will die. So breathing is not just about supplying oxygen, it's about getting rid of that waste product, CO2. All right? That's where we start. How are we doing with that concept? So, because our PCO2 is so related to our pH, because CO2 combines with water, forms carbonic acid, you get a proton and a bicarb. When our level of CO2 is intimately related to our pH. If our pH is too low, we go into a coma and die. If our pH is too high, we go into convulsions and die. It's a huge part of homeostasis of keeping our pH. We live between 7.35 and 7.45. That's your system is only tolerating that much of a difference because hydrogen ions react with proteins all over the place and just cause all kinds of problems. So a big part of helping us with our pH is breathing. So PCO2 is a big part of making us breathe. If our PCO2 goes up, we're not breathing enough. So the PCO2 goes to your chemoreceptors and says, you better breathe and get rid of this. If your PCO2 is too low, you're breathing too much. And a low PCO2 will tell your brain, tell your chemoreceptors, you better slow down. That's the general concept. How are we doing with the general concept? So, you have peripheral chemoreceptors. So, in the aortic arch and in the bifurcation of the carotids. Those are the peripherals. And they monitor arterial CO2, because remember, we don't care what's in the veins. Arterial CO2, arterial O2, and pH. If your pH is too low, if your CO2 is too high, the chemoreceptors depolarize, send action potentials to your central respiratory centers and say, you need to breathe to maintain homeostasis. The CO2 also can cross the blood-brain barrier and through the carbonic anhydrase system get converted into a hydrogen ion and a bicarb. So what's being measured is arterial CO2, but what's stimulating the chemoreceptor is the hydrogen. That also will tell your central chemoreceptors to depolarize. That's right next door to your respiratory centers, and they'll say, you better breathe. If PCO2 is too low or your pH is too high, you don't have enough hydrogen ion around. Those will inhibit depolarization. Those will inhibit ventilation, and you'll breathe less, and you'll build up the CO2 and get yourself back to where you should be. And you could try hyperventilating for 30 seconds and then stop, and your respiratory rate will decrease for a while you're reestablishing your set point. You can do that when you get home so your roommate can wonder about you. Now, there's one more thing we can monitor, that's oxygen. And the thing is, as we're walking around the world, we're usually not worried about oxygen. There's plenty of oxygen in the air. There's plenty of oxygen in our lungs. Typically, oxygen is not driving what we do, except when we go to altitude. So when we go to altitude, then we're breathing an air that has a lesser quality. We're breathing an air that, because atmospheric pressure is less, 20% of a lower atmospheric pressure means our PO2 is lower. And we run the risk of having O2 levels that are less than what we need for metabolism. And where's the threshold for that? When the PO2 gets about 60. When it gets about 60, we're in danger of not having enough oxygen to do what we need to do. And then that will start to drive ventilation. And the cells, the only place those cells are in the periphery. We don't happen to have oxygen sensing cells in the brain with the centrals. So that's peripheral versus central chemoreceptors. But the question that initially started was, why does your arterial PCO2 increase ventilation, and then the increased ventilation decreases your PCO2? Well, that question describes the beautiful negative feedback mechanism that you're doing all day long. If your PCO2 goes up a little bit, it's a very strong drive of ventilation. You will breathe more. You will breathe it off and get it back to where it needs to be. If you breathe off too much, you'll inhibit ventilation, you'll breathe a little less, and you'll get it back where it needs to be. So that is a beautiful explanation of how the whole thing works. And why is it negative feedback? Well, your CO2 is too high. What's the response of the system? You breathe more. You get it back down to where it should be. The response opposes the stimulus. If your CO2 is too low, it inhibits ventilation. You breathe less, you get CO2 back to where it should be. The response opposes the stimulus. Negative feedback. So I said this to somebody after lab, and I'll say it to the person who asked this question. You got to stop and think where you're starting. You're getting confused because you don't know where you're starting and when you're ending. And physiology is a big circle. It's perfectly understandable. But you have to stop and think, okay, is she asking me about the stimulus, or is she asking me about the response? Clarify that for yourself. And most of the time, I'm asking you for the next step, or maybe the next two steps. But the problem that students have sometimes is they'll go, well, A affects B, and then B affects C, and then C does this, and then D does that. Next thing you know, you're way down the road, and you're far away from what I asked you in the first place. I understand how that can happen, because everything's related to everything else. But my questions will be a little bit reductionistic, because I'm asking you for the most direct thing, or the, something that's very near to the process. I don't know if that's making any sense. But if you find yourself in the middle exam and you just think, what the heck is this woman talking about? Well, first of all, you know you can ask me. And I will clarify the question if I can. I can't confirm your answers. Sometimes students get annoyed with me because they say, well, I know A is true, but B is kind of half true, and I ethically cannot comment on that. I can help you with a word or help you with a wording or that kind of thing, and I'm happy to do that. But try to figure out what the question asks. Once you got the question down, then say, okay, I'm just looking at these two things, or and you know, and rein yourself in instead of going 12 steps down the road, because I'm not asking about 12 steps down the road. I'm asking about step 1. Okay, so we've gone through the topics. Do we want to generate more topics? No. Okay. Okay, it's 4:30. We've been working for an hour. That's enough for anybody. Okay, so let's see how our recording went. And so this is Dr. Anderson. I am saying goodbye, and I'm going to upload this to YouTube and give you the diagrams.